Morning, everyone. Good to see lots of bright and fresh faces this morning. So I wanted to welcome everyone here and online to our second session of the RMP Summer Series. Before we begin today, I just wanted to acknowledge and extend my apologies for a mix-up last week regarding some of our colleagues at Odette and the schedule change for Dr. Han's talk. This has been rescheduled to August 17th, and so please join us at that date. So this morning, it's my pleasure to introduce our colleague, Dr. Eileen Rakovitch, for our talk. She is an academic radiation oncologist at the Odette Cancer Center and an international expert in the management of breast cancers in DCIS. She is the Elsie Campbell Chair in Breast Cancer Research at Sunnybrook and the Research Director of the Odette Cancer Program. She is a professor and the Vice Chair of Clinical Affairs in the Department of Radiation Oncology at the University of Toronto. And lastly, she's the co-chair of the Breast Cancer Disease Site Executive at the Canadian Cancer Trials Group. So please join us in welcoming Dr. Rakovitch for a talk this morning.
Good morning. So nice to see so many of you in person. And thank you very much for the invitation to come and speak to you today. It's really wonderful to be back here. It's been a long time and to be together in person. So I thought as I put this talk together that on the role of genomic biomarkers to guide the management of ductal carcinoma in situ, I thought I would also present it in a way that serves as a prototype. Most of you do not treat DCIS. Most of you treat invasive cancer, but you know, there has been thousands, hundreds of thousands of molecular studies that have identified molecular profiling, molecular signatures associated with recurrence, progression, response to treatment, but very, very few have actually made it to sustainable clinical utility to help us in our decision-making, to help our patients. And so I thought, DCIS, think about it more in the work that we've done and our team has done as a prototype of some of the pitfalls and the challenges to translate and to take molecular discovery science to the clinical, to have sustainable clinical utility. There we go. Okay, here are my disclosures. And I'm going to start with the acknowledgements because the work that I'll present to you today is by no means work that I've done alone. We are a team. I've been so really privileged to work with so many tremendous people, including some of our younger faculty who have joined our research team. Now, DCIS is a non-invasive form of breast cancer, and the risk of dying of breast cancer overall for individuals, and predominantly women who are diagnosed with DCIS, is about 2%. It's very rare. Yet there's been a tremendous amount of media coverage, concern, public health concern about DCIS. Why we need a new war on cancer. A walking time bomb, but DCIS is not cancer. Our US Congresswoman discussing DCIS. Martina Navratilova recently diagnosed. The New York Times highlighting. There's been tremendous media coverage about a non-invasive breast cancer that's associated with a very low risk of mortality. And so I'm going to highlight to you the work that we've done over the past 2 decades and why this is such a public health concern and what we need to do to try and improve the treatment. And the story of DCIS begins with the implementation of mammographic screening. As you see here, that DCIS was very rare before the widespread implementation of screening mammography. And with screening mammography, there's been a logarithmic increase in the detection and the diagnosis of ductal carcinoma in situ. And we all are very familiar with the benefits of mammographic screening, but with screening, there are risks, and the detection, the diagnosis of DCIS is often considered one of the harms of screening. The reason for that is because women who are diagnosed with DCIS, predominantly women, are detected in the absence of any symptoms. You see here the classic mammogram with pleomorphic calcifications. Women, most do not have any symptoms and are otherwise well. And DCIS is very common. 1 in 1,500 mammograms results in a diagnosis of DCIS. It's now 25 to 30% of all newly detected breast cancers. Over 60,000 women are diagnosed annually in the United States alone, and 5,000 in Canada. It's very common. And the concern is that we also know there's what is referred to as a baseline prevalence or a disease reservoir. So if we look at autopsy data of women who died of other causes with no history of breast cancer or DCIS in their lifetime, we find that up to 15% will have evidence of DCIS. It's very similar to the low-grade prostate cancer story in men. And so there is concern with soliciting screening and biopsying women. There's tremendous concern of overdiagnosis. Overdiagnosis is the detection of tumor through screening in the absence of symptoms that would never have become clinically evident in the absence of screening. And so you can see the curves there. And overdiagnosis can occur because the tumor is very indolent and would never have manifest during a woman's lifetime, or if she has competing risk of mortality. And the concern about overdiagnosis is it leads to overtreatment. On the other hand, some women with DCIS do go on to get invasive breast cancer. And the development of invasive breast cancer after DCIS is associated with a significantly higher risk of breast cancer mortality. You see the curves on the right, data from 2 randomized studies of DCIS, the NSABP-B17 and the EORTC. Both are randomized trials of local excision with or without radiotherapy. And what you see here is that individuals who developed an invasive breast cancer after DCIS in the same breast had a 7 or 17-fold higher subsequent risk of dying of breast cancer. So for some women, DCIS is a precursor to invasion, and that invasive cancer requires more treatment and can lead to a high risk of breast cancer mortality. And the challenge for 2 decades has been in the identification of these individuals, of these lesions that are truly precursor, or of individuals in general who are at risk of developing invasive cancer from those that are not. And overall, about 5 to 10% of women with DCIS will get invasive cancer, but we cannot identify, until today, we cannot identify who they are. So we treat everyone, leading to tremendous, we know we overtreat many, many individuals. So how could we collectively, as clinicians, clinician scientists working with our discovery scientists, how do we move forward to reduce this tremendous amount of overtreatment of this non-invasive disease? Therein lies the dilemma. So because of this potential to progress to invasion and its associated mortality and our inability to identify that subset, guidelines recommend that all women diagnosed with DCIS undergo treatment. And the majority have localized disease and that will be treated with breast-conserving surgery. And there's been 4 randomized trials that have shown the efficacy of breast radiotherapy after local excision for DCIS. And here are the Oxford overview, the early breast cancer trialist meta-analysis of the 4 randomized trials. All delivered 50 gray and 25 fractions over 5 weeks. But you can see the curves on the right that in the absence of radiation treatment at 10 years, 28% developed local recurrence. With radiotherapy, it was reduced by half. And half of the local recurrences are invasive cancer. No difference in breast cancer mortality. So these trials really served as the basis that continues today to offer radiation treatment for women with breast cancer, with DCIS. And this shows you that the risk of breast cancer mortality overall for individuals with DCIS is about 2% at 10 years. And I just highlight for you here that the risk of dying of other causes far exceeds the risk of breast cancer for this population. The other point I want to make about this slide is that breast cancer mortality is not the only endpoint. As I mentioned, women who develop invasive recurrence require additional treatment, more surgery, systemic therapy, possibly chemotherapy. And because the treatments are quite effective, many of those women won't die of the disease. So mortality alone is not the only relevant endpoint. It's all the associated morbidity and psychological morbidity of an invasive recurrence that we're trying to prevent with radiotherapy. Number needed to treat to prevent 1 local recurrence, 6 to 10, not invasive, 10 to 20, very reasonable numbers to treat in order to prevent local recurrence and particularly invasive local recurrence. Boost radiotherapy, which is supplemental radiotherapy to the tumor cavity, was shown to offer an additional, for women with slightly higher risk of recurrence, you can lower it by another 4% if you boost radiation. So these trials really set the stage for the standard treatment of breast conserving surgery and radiotherapy. And most individuals until today continue to receive local excision and radiotherapy. And despite this, treatment guidelines for well over a decade have included a recommendation that it's okay to omit breast radiation treatment in individuals who are deemed to have a low risk of local recurrence. So there have been many efforts to identify individuals at low risk of local recurrence where it would be safe to omit radiotherapy. And the initial trials were based on clinical and pathological risk factors of DCIS, the usual ones, the age, tumor size, focality, margin status. And the initial seminal study was run by ECOG-ACRIN, the 5194 study, which used clinical and pathological parameters to identify a subgroup of women deemed to be at low risk of local recurrence, where it would be safe to omit radiotherapy. These are single-arm prospective trials of breast-conserving surgery alone, and low risk was defined as either having non-high-grade DCIS less than 2.5 centimeters, or very small, less than a centimeter, high-grade disease with clear margins. And a Boston group did similar to cohort 1, E5194, local excision blood. And what we found at about 10 years for cohort 1 in yellow, the risk of local recurrence is about 14%. In Boston, it was 15.6%. Cohort 2, small high-grade lesions with clear margins, 25%. Had a local recurrence. Half of those recurrences are invasive. The NRG 9804 study evaluated radiation in these low-risk women, similar to cohort 1, non-high grade, less than 2.5 centimeters with clear margins, and showed a substantial benefit, similar. Without radiation, 11.4%, with radiotherapy, 3%. And the invasive rates are down below. So there have been continued efforts to identify women where we could safely omit radiation treatment. We'll go back to the EBC-CTG meta-analysis. Every single subgroup defined by clinical pathological parameters benefited from radiotherapy. So this didn't help us identify those subgroup at low risk where radiation can be omitted. And as a result, most women continue to receive radiotherapy. If we look at data from the United States, from SEER, 1991 to 20, women diagnosed between 91 and 2010, the majority, if anything, of increase, continue to receive breast radiation after local excision. So despite guidelines, despite the 5194, radiation continues to be administered. Now, we looked about 2 decades ago now, we established a population-based cohort of DCIS in Ontario. We identified all women diagnosed in Ontario from 1994 to 2003, pure DCIS through ICES. And we did a pathology review. So we did a systematic pathology review of thousands of cases so that the pathological criteria are by modern standards. One of the things we looked at is the treatment and the associated outcomes. That was one of the first analyses. And we see here that we identified women with pure DCIS. We excluded anyone who had prior malignancy, including breast cancer. So this is de novo disease. And that we identified just under 4,000 women. Half of the women did not receive radiation treatment. So this means that clinicians felt that their risk was low enough that they can omit radiation treatment. And they did have some lower risk clinical and pathological features. But at 10 years, the recurrence risk was 20%. Half of them were invasive recurrences. And although women who received radiotherapy had higher risk disease, they had a lower recurrence risk because they received treatment. And then we looked specifically at the subset that met that cohort 1, 5194 low risk criteria by every known clinical and pathological feature. 10-year recurrence risk, 14%, quite consistent from the other studies that I've shown you. And so with all of this work, there's been a big challenge to de-escalate and reduce the overtreatment of DCIS. Overall, using clinical pathological criteria with clear margins, the best we can get is a 10-year recurrence risk ranging from 11 to 16%. Radiotherapy reduces this risk in all, in all subsets defined by clinical pathological factors. Patterns of care studies show that most women carry on and receive radiation. Most clinicians recommend it, most women receive it, which means that these 10-year risks of 11 to 16% are too high for consensus to omit radiation treatment by both clinicians and by individuals. Clinical and pathological features alone cannot identify individuals with a very low risk, and I would say that means less than 10% at 10 years in the absence of further treatment. And multi-gene signatures help. So molecular biomarkers are costly, and they take 2 or 3 weeks to get, depending on the signature. And so we have focused a lot on trying to identify their role. And again, this serves as a prototype. Every single tumor, we're in the same situation. How do we evaluate the prognostic utility of multi-gene signatures to improve treatment of our diseases and our patients? So in general, a molecular signature can improve clinical decision-making if it's either prognostic and improves the risk stratification. So in the example of DCIS, if a molecular biomarker can better identify women at very low risk, less than 10% at 10 years, where there would be greater consensus to omit radiation treatment, then it can have clinical utility. Cost effectiveness aside, talking about the potential clinical utility. And conversely, if it identifies women at high risk, then we know we can better target our efficacious treatment, radiation boost, endocrine therapy, et cetera, to those that are indeed at high risk. A molecular signature can have clinical utility if it can predict radiation response or treatment response. And that requires that the demonstration of a significant interaction between the biomarker and the therapeutic intervention or radiation in this case. So there are 3 commercially available assays. 2 of them are commercially available for DCIS, the Oncotype 12 gene DCIS score, which is 12 of the 21 genes of the Oncotype recurrence score, which has prognostic utility and RMP prediction, or certainly prognostic for early stage hormone receptor invasive breast cancer. And the third assay called the Decision RT Decision Score, DCIS RT Decision Score. And what we know in DCIS and from this work is that putative molecular alterations are detectable and are present in a substantial proportion of DCIS. So one of the challenges in the molecular work of DCIS is we don't have fresh frozen tissue. We work with paraffin embedded tissue, often quite old, and it's very challenging to do molecular profiling, but we can detect it in FFPE, in DCIS. We do find alterations that are putative in invasive disease. They are present in DCIS. So here you see 25% of individuals have a high-risk DCIS score. About 50% had a high-risk decision score, and 30%, in fact, and I'll show you a little later on in the talk, have a high-risk recurrence score, which is associated with distant metastases in invasive disease. And so we know that we can detect these putative alterations, but are they associated with adverse outcomes? So the first molecular assay to be demonstrated to have prognostic potential utility is the 12 gene DCIS score. The DCIS score is a continuous score from 0 to 100, and then it's categorized low, intermediate, and high risk, as you see here. And in the E5194 study, it was the first study to show that the DCIS score indeed is associated with ipsilateral local recurrence. Here you see the Kaplan-Meier curves on the right, and in blue, individuals with a low risk DCIS score had a lower risk of local recurrence compared to those with intermediate and high risk. We externally validated the Oncotype, the 12 gene score. You see here we used tissue from the Ontario cohort. We obtained the DCIS score, and you see there our Kaplan-Meier curves. I think the point here is that this is a completely external independent population from 5194, and the 5194 was very highly selected. This is a diverse population, and you can see the outcomes are remarkably similar, that the risks stratified by low risk versus intermediate high were the same. The other assay that's clinically available is called the DCIS, or the decision score. And this assay is a compilation of both molecular factors and clinical factors, as you see here. And the initial study was based on just over 500 patients treated with breast-conserving surgery with or without radiotherapy from 2 institutions in Sweden and the University of Massachusetts. And they scaled the decision score from 0 to 10 with 2 risk groups with a threshold of 3.0. And you see the initial analysis of the sample showed that individuals with a low risk score had a lower risk of local recurrence compared to those with an elevated group, and a greater reduction with radiation treatment. So the investigators concluded that this assay was both prognostic and predictive, because the absolute benefit was greater in individuals with an elevated risk group. Now, external validation was performed with individuals in the SWEDE DCIS trial. I think this highlights the importance of external validation. So about half of the participants of the SWEDE DCIS trial were able to have the decision score. As you see there, half had a low score, half had a high score. And what they found was that the decision score, in fact, was not prognostic, nor was it predictive of radiation benefit. So you see in the bottom there, the interaction between the effect of radiotherapy, or the hazards ratio of radiotherapy, and the decision score was not significant. And I think it also highlights the caution of claiming prediction in the absence of seeing a significant interaction. We will see a greater absolute reduction. If the relative benefit is still the same, you will see a greater absolute reduction in someone that has a higher risk of recurrence. That is not the same as prediction. In order to have predictive utility, what we need is, among patients at high risk, does our assay identify radiation sensitive or radiation benefit, where radiation would be useful, versus radiation resistant disease, where alternative therapy is needed. And this holds true whether it's DCIS or any invasive disease. The distinction between what a true predictive biomarker will give us, and not to confuse that with a prognostic biomarker, which then would have a greater absolute benefit from a treatment intervention. So the bottom line is, for this study, it shows the real importance to external validation. And the lack of doing that, I believe, has led to limitations in the sustainable clinical utility of many of our biomarkers. So after this negative study, then what the investigators did is they looked and altered the threshold. They allowed the threshold for the decision score to range between 1 and 3 to see if they would find a statistical significant interaction, and they did when it was 2.8. So they redefined the assay, now having a threshold of 2.8. And of course, there's concern about multiple comparisons and just kind of fishing. And but the investigators did that. They found 2.8 might be a better threshold, added another biomarker for the EGFR KRAS pathway, and published what is now a refined or novel biosignature. The other point I just want to make, because I think this highlights a lot of the potential limitations and pitfalls as we move to biomarker discovery. So the need for external validation and post-hoc analyses, which are fine, but they went back and tested this novel biomarker in cases from US, Australia, and Sweden. But US and Sweden were the same cases as the original cohort was used to define the original assay. So it's not independent. So I would say that this requires independent external validation. What we need to be sure with novel biomarkers is that they will ultimately provide us, more importantly, our patients, with accurate, reproducible estimates of outcome or estimates of our treatment response that is reproducible and valid in multiple independent populations. And external validation is very key to ensure that. At the end of the day, we are providing our patients with accurate information about their risks and their response to treatment. So some of the pitfalls or limitations in biomarker discovery in general is that it originates from retrospective analyses. It's performed predominantly in available FFPE tissue from selected patients, highly selected patients, limited by specimen quality and missing data, and requires overfitting of data to identify significant associations to optimize the performance of the assay. For these reasons, external validation is required in independent, unselected patients. Now, I just want to shift to prediction. We're all here working towards precision oncology or personalized cancer therapy. And I think we need to identify and distinguish overall summary statistics from individualized outcomes. What I mean by that, if we go back, for an example, and we look at a Kaplan-Meier curve, and we would tell our patients in the absence of radiation, your risk is 20% and 13%. That represents a summary statistic of a subgroup of patients treated the same. It's an average. It's not individualized. Some will have much lower. This will be an overestimate for some and underestimate for others. So to move forward with precision oncology and personalized cancer therapy, we need to recognize the individual heterogeneity, and predictive modeling does that. So in distinction to association analyses, which we're all quite used to when we look back and look for causal relationships or associations between covariates and outcome, predictive modeling and predictive analyses enable us, through the derivation of an algorithm, enable us to predict the probability of a future event for an individual. It uses statistics to calculate the probability of a future event. So it's a very complex equation with transformations or not of different parameters. It is based on observed outcomes in a training set compared to observed outcomes in a cohort. And a predictive model also requires internal and external validation to ensure that it's predicting or estimating recurrence risk accurately in order to guide treatment recommendations, as I mentioned a few minutes ago. Now, the performance of predictive models can be measured using a C-statistic or concordance index, where we measure the performance of the model. So did individuals who were estimated or predicted to have a low risk of recurrence, did they not recur? Did individuals estimated to have a high risk of recurrence, did they recur? How well did that model perform? C-statistic. And calibration plots, again, as you see here, where the red line is perfect calibration, and you see the blue line of the predicted versus the observed probability of an event. So we looked at the DCIS score, the 12-gene assay, to see if it can help optimize the individualized prediction of local recurrence risk, and importantly, invasive local recurrence risk for women with DCIS. We collaborated with ECOG Akron, and we combined the data from 5194 and the Ontario cohorts. And we looked at women treated with breast-conserving surgery alone. That's what's key. What's the outcome in the absence of doing anything else? And we had combined 773 patients, and then we evaluated 3 predictive models, one based on clinical and pathological features alone, one based on the score alone, and then combined. And what we found was the best model that most accurately predicted an individual's risk of local recurrence was a model that included the 12-gene assay and clinical factors, tumor size, and age. All the analyses were adjusted for year of diagnosis. You can see our calibration plot here is quite good. Now, we then did additional and more comprehensive predictive modeling. This was published by Larry Pizzat, one of our colleagues, also looking at more comprehensively tumor clinical pathological features, the DCIS score. And then we looked to see perhaps just ER and HER2 status. Maybe that's good enough and we can save on the expense of the assay. We found the same thing. When you integrate the 12-gene assay, predicting outcomes and recurrence was more accurate than a model that excluded this 12-gene assay. And our work led to a modification of the Oncotype DCIS score report. You can see here, this is what the current DCIS score report looks like. You enter in the patient's age and the tumor size when you order the assay. It's very similar to the recurrence score. A sample of tissue from the FFP is sent to Exact Sciences, and they give you this report. You get the score from 0 to 100, and then you get an individualized estimate based on our algorithm on the probability of local recurrence at 10 years in the absence of any treatment, no endocrine treatment, no radiation, and an individual estimate of the 10-year risk of invasive cancer. And this, I think, is hopefully going to help us move forward towards personalizing, because for any given risk, one individual might want treatment, another one might not. It's not so much about saying everybody has to be treated the same way, but it is about providing more accurate individual estimates of the outcomes to better guide decision makers. So we then look to see, okay, these assays are important. Can they actually change treatment recommendations? So we did a Canadian-wide study called Duchess, where we examined whether the DCIS score report can alter physician or rad-onc recommendations for radiation treatment. Would women accept to omit radiation treatment, and by what extent? And would they have? And we measured their satisfaction. This was a study we ran nationally with OCOG, and we asked clinicians to estimate the risk of local recurrence. And would you recommend radiation? Yes, no. And then we got the DCIS score. They got the report. We compared the estimates provided by the algorithm with clinician expertise. And we compared whether or not that changed their recommendation and whether women accepted that. What we found is without the assay, only 6% were estimated to have a recurrence risk less than 10%. And that's understandable from all the data that I just showed you, that clinical path factors at best, 11 to 15%. But almost 45%, almost half of the women had a 10-year predicted risk less than 10%. The other thing we learned from Duchess is that with that threshold of 10% or less, 83% of radiation oncologists recommended no radiation, and the women accepted that with high patient satisfaction. Once the recurrence risk is over 10%, 66% recommended RT if it was between 10 and 15, and almost all if it was greater than 15%. So Duchess, the study was very informative because it did show us that integration of the molecular assay can identify substantially more individuals who have a very low risk of recurrence. And it also showed us that there's quite a lot of consensus that if that recurrence risk is less than 10%, that radiation oncologists and individuals, there'd be greater consensus to omit radiation treatment and hopefully move us forward in reducing the overtreatment of DCIS. Now we are opening up the ELISA, which is prospective validation of what I just showed you, this study, and PM Margaret has opened the study as well. 13 centers across Canada have now opened up this study, the ELISA trial. And it is prospective evaluation or validation for women over 45. Younger women are thought to have a higher risk of recurrence with these smaller 2.5 centimeters tumors, clear margins. And if the DCIS score predicts the 10-year risk of recurrence, local recurrence is less than or equal to 10%, radiotherapy is omitted and they're followed. We anticipate we need to screen about 800 women to find 526 eligible patients to have sufficient precision around our estimate, and that we will complete accrual within 3 years. And here's the schema. So individuals who are eligible are approached to get the Oncotype DCIS score. And it takes about 2 weeks. We get it back. If their predicted risk of local recurrence at 10 years is less than or equal to 10%, radiation is omitted, and we follow. And if it's higher, then they get treated accordingly. Primary outcome is local recurrence with the usual secondary outcomes in breast cancer studies. So we hope that the prospective validation will again facilitate and clarify the clinical utility and the ability to de-escalate therapy for women at very low risk of recurrence. But in addition, it can identify individuals at higher risk of recurrence. We don't know currently who to boost or who would benefit from endocrine therapy. In the United States, most women get endocrine therapy. In Canada, they don't. But again, so the utility of these predictive models and these assays is not only on the low risk end, but it's also for higher risk women where we can more effectively target our interventions to reduce their risk. So I just want to shift for a moment because, as I mentioned before, really the key driver of overtreatment is our inability to identify women who truly are at risk of developing invasion, and that continues to remain a challenge today. And as I showed you before, the development of invasive local recurrence is not benign. It requires treatment and is associated with the risk of mortality. The 21 gene recurrence score has well-proven prognostic utility in hormone receptor positive breast cancer. And that individuals in particular who have a high recurrence score defined as greater than 25 have a higher risk of distant metastases than those with a lower recurrence score. So we then went back, when we did the initial validation study of the DCIS score, we also acquired the 21 gene. We acquired individual gene data and a 21 gene assay. So we went back to say, we wonder if the recurrence score is actually present in situ, and if a similar threshold is associated with adverse outcomes in DCIS. So we specifically wanted to know, is the presence of a high recurrence score in DCIS associated with a higher risk of breast cancer, or even if the higher risk of breast cancer mortality. So the study included almost 1,400 patients. Median follow-up at that time was 16 years. And as I've shown you, it's quite consistent overall for the Ontario cohort. About 2.5% of women died of breast cancer. We did a propensity-adjusted model, accounting for competing risk of death of other causes, because most women die of other causes, and calculated from the competing risk model the 20-year cumulative incidence of developing invasive local recurrence and of dying of breast cancer. And I should note for that all of our outcomes were validated. Okay, so what we found is almost a third of lesions, 30% of index DCIS lesions had detectable high recurrence score greater than 25. And that for those individuals who had a high recurrence score, and I remind you, it was not known at the time, but for those individuals, they end up having a subsequent much higher cumulative risk of developing invasive local recurrence. And particularly for younger women under the age of 50 who had a high recurrence score and did not receive radiation treatment, they had a substantially higher risk of dying of breast cancer. So their risk of breast cancer mortality was 9.4%. And this was the only subset, younger women with a high recurrence score who did not get radiation, whose risk of breast cancer death far exceeded the risk of dying of other causes. In addition, what we found was for those individuals who had whose DCIS had a high expression, a high recurrence score, treatment with radiotherapy was associated with a substantial reduction in invasive local recurrence and a substantial reduction in breast cancer mortality. So this needs to be validated, which is very challenging, but it really starts to give us clues that the same putative molecular alterations that we see in invasive disease, at least in invasive cancer, are detectable in DCIS and may also confer very bad prognosis, may identify the subset that really require treatment to prevent high-risk invasive breast cancer. So I should know what we are doing now under Ezra's leadership is we have acquired blocks of the recurrences. And we are looking to see to validate what our suspicion is, that those that recurred with the DCIS that had a high recurrence score, that had an invasive recurrence, that their invasive recurrence, in fact, was high risk. And that would really, I think, shed a lot of light in regards to these are high risk precursor lesions that need to be treated. So we're in the process of doing that. So reducing the overtreatment, I've tried to show you, has been very challenging. I do believe that genomic assays have the potential to improve the management of DCIS. There is ongoing work looking through discovery science on molecular alterations and signatures and the DNA and RNA full sequencing. And I tried to show you some of the challenges that we as clinician and clinician scientists have to actually getting these biomarkers into the clinic to have sustainable clinical utility. Particularly for DCIS, we see that these high-risk putative molecular alterations are present and are detectable in a substantial proportion of DCIS, and they do confer a worse prognosis. The 12-gene assay, I think, has been most rigorously studied, and it does improve the predicted risks of local recurrence and invasive local recurrence, which can help clinicians and patients better weigh the risks, benefits of treatments. More work is needed to identify specifically the individuals that will develop progression and the underlying mechanisms of progression to invasion. If we knew that, we would know who to treat. We would much more substantially reduce overtreatment. And separate research is needed to identify signatures that predict radiation response. Internal and external validation is very important to ensure that ultimately we provide our patients with accurate estimates of their outcome and accurate estimates of their response to treatment, to optimally guide treatment recommendations as we move to precision oncology and personalized cancer therapy. I think this is very important. This will help in better inform decision tools, reduce the progression to invasion, and reduce the impact of overdiagnosis and overtreatment of DCIS. Again, thank you for inviting me today, and to all of my colleagues that participated in this work.
Thank you, Eileen, for that talk. So now we'll open the floor to any questions from the audience or from online. So I think Jan, for the question.
Thank you very much. That was an outstanding presentation as well as track record of publications.
Thank you. Thank you.
I was wondering about, you talked about biomarkers, but I was wondering about the imaging biomarkers to supplement prediction modeling. What are your thoughts about it?
I think that imaging and radiomics are going to have a very important role. And they complement the understanding, the molecular drivers of progression and of treatment response, and then to see if that can be detected through radiomic signatures. So it hasn't right now, certainly in DCIS, hasn't panned out, but I think that's a whole area of work to work together to understand the proteome spatial relationship, and then to see if we can pick that up in imaging. Complex, but I think they're complementary.
Yeah, so I was great talk and also lots of good content and food for thought. I was thinking about, so first I'm happy that Ezra is going to tackle these kind of score concordance between the DCIS and the invasive down the line. But perhaps a question upstream of that is how many of the so-called recurrences are truly recurrences and not a completely de novo or independent tumor from a field defect that it's kind of highlighted by the presence of DCIS? Has that been kind of dissected?
Slowly. So the short answer is about 80% are clonally related to the index lesion. The majority that recur in the same with similar morphological features. So many are. Part of that is depending if they recur elsewhere, and also time to event. So we looked, I didn't show you, but we looked at the hazard function over time. And what we found is that really the recurrences that happen within the first 7, maybe 10 years are much more likely to be clonally related to the index lesion, and that beyond 10 years, they're probably independent. And in fact, we show that the effect of radiation is for the reduction in the hazard function of the early recurrences. Doesn't affect later because it's probably de novo lesion, and upfront radiotherapy doesn't affect that. So we, in our sequencing, which I didn't go into, but we've done full transcriptome sequencing, and we're just analyzing the DNA-seq. We're going to be able to look at the clonal relationship between the early events, which we believe are clonally related, and the late events, which we believe will be probably de novo disease, to shed light on that, because that would be different. Someone has a high incidence of late, then they need endocrine therapy, not necessarily radiotherapy, right? And so that work is evolving. The challenge is acquiring the specimens and the FFP reliance, the degradation, et cetera, as you all know. So that's been the challenges in that.
I should have looked at it, but on the 21 or 22 signature, is BRCA1 another hereditary germ? So what's the influence of germline mutation on your DCIS risk?
So interestingly, germline mutation is more at risk for invasive than DCIS. And once you get DCIS, it doesn't alter the prognosis.
How do you know that? Test for that?
In our cohort, no, just in general, the general literature. So we haven't looked specifically at germline mutations. We could. Yeah, we could. We could.
Thank you for the wonderful talk. Are there any algorithms combining the gene signature with blood liquid biopsy for predicting recurrences?
It's a good question. So we'd have to, if they were biopsy DCIS, then do blood at that time, and then see the final pathology that doesn't have invasion. So I haven't seen data on that. We haven't done that. It's a good thought, though. We could do that.
Really nice talk from a physics perspective, seeing partner meeting models, which is quite interesting. On the other hand, I'm just kind of curious about sort of the behavioral sciences, or there's all sorts of studies done in behavioral sciences and how people understand probabilities and what they do with them.
Yes. Yes.
And so I'm kind of curious downstream, how do people, clinicians and patients, use this data?
Yes.
Will they make decisions that make sense to us, or like how is that to be done?
No, I think that's an excellent question. And what we do, we published this 20 years ago, but we know that there is, and I think that's the new war on cancer. There's a lot of confusion of DCIS and breast cancer and its risk. And we evaluated that many years ago, and others have as well. So one is, ductal carcinoma in situ doesn't really mean anything to most people. And certainly the fact that it's associated, I spend more time with a patient with DCIS than with invasive cancer, explaining, and then having and there is a fear of breast cancer, invasive fear, which also has contributed to the ongoing overtreatment, right? How low is low enough? So I think there is a fascinating behavioral science component to all this. And my approach has been not to be dogmatic about you need treatment, you don't, but to provide most accurate estimates. Because I think those summary statistics, and we all do this in all cancers, they're not individualized. And so we are over treating, we don't even know we're doing that. But if we can all move towards, to the best of our ability, accurately identify the recurrence risk and the treatment benefit, then the patients can make their own decisions on what they want and at what cost, right?
Yeah, it just seems like patient education around that aspect is going to have to be enormous, right? Because, we saw it during COVID, people's estimations that are understanding the probabilities is.
Yeah. Well, the nice thing about, and I have nothing to do with the company, but the nice thing about the report is it explains it, and in lay language, what does the 6% risk mean, right? And so it's just the beginning, especially in DCIS, it's the first tool that you actually have a piece of paper that you can start to have that conversation.
Ben, fantastic talk and tremendous work to do all this. So congratulations to this body of work. Speaking of over treatment and trying to personalize risk for patient, I was actually struck by you showed an earlier slide where there's treatment utilization. And one thing that was going up was actually bilateral mastectomy for these DCIS patients.
Yes.
And just some of that perhaps from the fears of, or identification of germline predisposition factors like he was mentioning. But I was wondering what you and your surgical colleagues or maybe behavioral scientists are viewing that and interpret that.
That's SEER data. So that's in the United States. We're not saying. Full disclosure, I'm an American citizen as well, so it's nothing to do with that. Yeah, and so some of that's been linked to the increased use of MRI in the diagnostic workup has led to more bilateral mastectomies. We're not seeing that at least in Ontario, in the data that I've seen, we haven't seen that rise. And it also relates to what we were just talking about, you know, the risk averse. So BRCA or germline aside, there is a real fear and, you know, to do that. So yeah, so we haven't seen that so much, but that's highlighted as an issue, particularly in the United States. Fifi Liu.
So we'll start with Jaime and then we'll
I have two questions. What are nightmares of surgeons that we should?
Yes.
Especially in DCIS. So how significant? What was 5 with our performance here? Was negative, was others close. What's the weight of the market?
Yeah. It's a challenge, as you know, Jaime, right? And it's a particular challenge when we omit radiation. We don't worry so much, right? We don't, when we're radiating, not so worried, particularly when there's no, you know, tumor on for invasive, but you need 2 millimeters for DCIS, right? So the RADOX and the we know that. I think it's, you know, for the ELISA trial, we said the radial margins have to be 2 millimeters, but the antin post is not 1 millimeter sufficient. There's a lot of variability in the surgical excision, going up to skin down to fascia, taking the fascia or not. So it's challenging. There is an effort now internationally to combine our observational data from all over the world. Actually, the statistics will be done out of Oxford to specifically look at margins. So it's very challenging. The data sharing agreements are very challenging from all over the world, and we're trying to get through that, but it's specifically to shed more light. And I think it's going to be of particular importance as we de-escalate therapy. Yeah.
We have a question from Fifi online.
Yes, can you hear me, Eileen?
No, I don't hear you.
Oh,
Barely.
okay.
1 second, we're just.
It's not you, Fifi.
It's not you, Fifi. Hang on 1 sec.
Oh.
Okay.
Can you hear me now?
No.
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 I can repeat you.
Sorry.
Hold on.
Give us 1 second.
Okay.
Could you try now, Fifi?
Okay, can you hear me now?
No.
No. Okay.
So Jan can hear her sitting back.
Oh, okay. Jan hears you, so he'll.
Oh,
Okay.
Jan can hear me?
Jan can hear you apparently.
Oh, that's very interesting. Okay, so
a little
Jan,
broken telephone. But okay.
yeah. So Jan, can you ask Eileen? So number 1, fantastic work, congratulations. And number 2,
thank you. I heard that.
Yeah. And then secondly, have you had an economic analysis on the cost of the Oncotype DX and the avoidance of treatment? Have you had an opportunity to do that?
Economic analysis of the DCIS score.
Right. And the avoidance of treatment. So the overall cost to the healthcare system perspective.
Yeah, so there was one economic analysis that was published showing that it was not cost effective. That analysis assumed that no one would have radiation, and then they would only have radiation if they had the score. But in fact, as I showed you, the antithesis is actually true when you look at treatment pattern studies. So the baseline is that everyone's getting radiation, and so it wasn't done in that way with that reference point. So no.
Yeah. Thank you.
Thank you, Eileen. Very interesting work. You presented towards the end. You presented very useful scores to identify the very low risk population and then a high risk of relapse with invasive. but I think you said that they have not yet been externally validated, and you commented there is going to be challenges with validation, and yet in the previous work from the Scandinavian group, you showed how validation is essential in an external independent data set. So can you tell us about your plans for validation?
So the 21 gene score work is or findings were really, I think, very interesting. We hypothesized that it might be, we didn't expect it to be so telling. In any event, because there are the randomized trials that I showed you don't have tissue, tissue is a big problem. So we were fortunate enough to get funded by CIHR, and we are establishing another contemporary cohort. We've established that 6,000 individuals, and we're currently in the process of acquiring the blocks for that. And so we are, it's separate from that, which I tried to focus this on commercially available assays, but we've also done full transcriptome sequencing, and we've identified a novel signature that predicts radiation response. So this new cohort can be used to look at the RS, the recurrence score, but also to refine and validate the radiation predictive signature that we discovered, which it does not only contain molecular alterations in breast. So it will be a real opportunity to look at prostate. You're giving your talk, I was thinking about that, to look at other tumors to see if it can also predict radiation response. I didn't get into that now, because I was more focused on the pitfalls of bringing commercially available assays to the clinic, but that's our plan. So we're in the process of establishing yet another population-based cohort. We had no choice.
And any external validation of the high risk for invasive recurrence?
Yeah, that's the other. So that's in process. We have the blocks of the recurrences. And so now I have a meeting with Exact Sciences to see if they waive the recurrence score, and then everything else we'd be able to do under Ezra's leadership.
Congratulations. Yeah, amazing to see the amount of work over time in a challenging area, especially looking at overutilization of radiation. I imagine your work, they have different reactions in different parts of the world. It might be different than here. So anyway, congratulations. Question is regarding the signatures a little bit, like I'm very curious too about the different signatures, early to non-invasive to invasive, but what about even more advanced? So high risk based on clinical scores or metastatic, is use of these signatures helpful in decision making or being utilized, or is it that everyone gets maximal treatment so they're not so useful? And more advanced.
So the 21 gene recurrence score, it currently only has utility in hormone receptor positive, HER2 negative, predominantly early invasive breast cancer, and where the backbone of systemic treatment is endocrine therapy. And so that if for those individuals that have a high recurrence score, their recurrence risk and benefit from chemotherapy. So that's standard. It is no clinical utility for HER2 positive or triple negative breast cancer. And so most DCIS is ER positive, and HER2 is not really well prognostic. So that's why we said, that's why we examined it in DCIS and found what we have. So I think, I'm not sure that answers your question.
In more advanced cancer? Or
in metastatic disease?
Or even more advanced food?
Yeah, well, node positive, it has clinical, yeah, no, it does. In hormone receptor positive, it has clinical, the RX Responder trial showed it has utility in node positive disease. Don't know.
How it changes treatment though? Is that the
No, it does identify women with node positive disease that may not require biomarker low risk node positive disease that may not benefit from it.
I'm not asking very well. In node positive patients, for example, or advanced, locally advanced patients, does the 21 score or the other genetic markers help in terms of prognosis? And some of the, I know the oncotype is not used in the locally advanced, but are there other ways in the more locally advanced that these scores help patients look at risk?
There are some assays, the MammaPrint and Blue. There are some other molecular assays that are guiding chemo versus endocrine alone, genomic high risk, clinical high. So yes, they have not been evaluated in DCIS. They're different. Yeah.
Other questions?
Thank you. Thank you very much.
Thank you, everyone, for joining us this week, and have a good day.